Hey guys, welcome back to ST3 Hacks, and today we're going to continue our pediatric theme and talk about SUFE or SCFE, whatever you want to call it, slipped capital femoral epiphysis, which is a Salter-Harris type 1 injury through the proximal femoral physis. Now, this occurs in adolescence due to mechanical and biological weakness of the growth plate, and the key concept here is that the epiphysis remains within the acetabulum, and the metaphysis, the femoral neck, displaces anteriorly and externally rotates relative to it. Now, this is not usually a single traumatic event. It is more commonly a gradual physeal failure under repetitive shear stress, particularly in the presence of predisposing factors. Now, risk factors can be grouped, so they can be congenital, mechanical, or endocrine metabolic. So the congenital demographic factors are age between 10 to 16, male predominance of approximately 2 to 1, a family history. More commonly, they are left-sided and they're associated with syndromes such as Down syndrome. Mechanical factors include obesity, which is the most significant modifiable risk factor. And then you've got endocrine and metabolic conditions such as hypothyroidism, hypopituitarism, and growth hormone deficiency, along with hypogonadism and renal osteodystrophy, which is most commonly associated with bilateral SUFEs. Now, endocrine causes should be particularly suspected in atypical cases, under 10 years and over 16 years, in bilateral slips and in patients with low BMI. There are classifications that you need to be aware of. So firstly is the LODER classification, LODER, and I consider this more like a stability classification. So this divides patients into stable, where they're able to weight bear, and unstable, where they're unable to weight bear. And this classification is clinically important because unstable slips carry a significantly higher risk of avascular necrosis, and stability is prognostic. The next thing you need to be aware of is the temporal classification, and it divides into acute or chronic. So acute is symptoms within less than 3 weeks, and chronic where symptoms are more than 3 weeks. And then there's acute on chronic, where there's chronic symptoms with a sudden drop and deterioration. Most cases are chronic or acute on chronic rather than truly acute traumatic slips. Long-term complications of SUFEs are osteoarthritis, avascular necrosis, residual deformity, femoroacetabular impingement, leg length discrepancy, and chondrolysis. The long-term aim of management is to prevent the deformity progressing and thereby reducing the risk of early osteoarthritis and eventual total hip replacement. So, in radiology, initial imaging is AP pelvis and frog leg lateral views unless the slip is suspected to be unstable, in which case a cross-table lateral may be safer. In the AP view, the Klein's line is drawn along the superior femoral neck, and the Trethewin sign is positive when the Klein line fails to intersect the lateral part of the femoral head. In the frog leg lateral view, you can use it to calculate the Southwick angle, and this is formed by a line along the axis of the femoral shaft and a line perpendicular to the physis. And the grading is mild, moderate, severe, with less than 30 being mild, 30 to 50 being moderate, and more than 50 being severe. If the radiographs are normal, but suspicion remains high, an MRI with the STIR sequence can detect early physeal edema. So it's something that is a nice golden pearl to drop it in. Now, key concerns: the priority is urgent stabilization to prevent further slippage. Ongoing displacement increases the risk of AVN, residual deformity, femoroacetabular impingement, and early osteoarthritis. And a delay in diagnosis is one of the strongest predictors of poor outcome. Moving on to our triple assessment, you want to start with a thorough history. Mechanism is often atraumatic or there's minor trauma, and pain may be in the groin, thigh, or referred to the knee, and you want to take a Socrates history about this. You can ask about the limp and duration of symptoms, screen for endocrine history, and take a full pediatric and ample history. The red flag you want to know and keep an eye out for is knee pain in an overweight adolescent with a limp, and you want to always examine the hip. Examination, checking for an antalgic gait or an externally rotated foot progression angle, reduced internal rotation, Drayman sign, which is obligatory external rotation during passive hip flexion. And you also want to assess the limb lengths and check the contralateral hip. And you can learn and read up about apparent and true leg lengths in your own time. Investigations include AP pelvis and lateral views urgently. If there is an atypical presentation, you may request an endocrine blood test and involve pediatrics early. An MRI with STIRs if x-rays are normal but suspicion remains high. Just to specify, because I don't really know what STIR was, so it's a short tau inversion recovery algorithm for an MRI, and it's basically specialized to suppress fat in the imaging technique. So it enhances visualization of abnormal fluid, edema, and tumors by basically suppressing that fat signal. Okay. Now, moving on to the management. This is an urgent orthopedic condition. And in your answer, you should say that you would manage this patient with an MDT approach with a specialist pediatric orthopedic consultant and refer to the local children's hospital as per regional pathways. Definitive management of this condition is classically treated with percutaneous in situ cannulated screw fixation. Now, there are a large number of controversies around the management of SUFEs. So, in some literature, such as Uglo et al.'s paper, there is a debate over optimal timing. However, delay in diagnoses clearly worsens outcome, and most units aim for urgent fixation, ideally within 24 hours. Then there's controversy about reduction during fixation. Routine reduction is not actually recommended due to the risk of ABN, and gentle positioning only is what sometimes is performed. Then there's the discussion of 1 versus 2 screws. 2 screws may increase stability, but they carry the risk of physeal damage and chondrolysis, and the evidence there is quite mixed. And then there's discussion of prophylactic fixation of the contralateral hip. The risk of a bilateral hip is significant, particularly in younger patients, between 20 to 40% in some papers. A recent BOSS study identified young age as the major risk factor for contralateral slips, and it recommended that children under approximately 12.5 years, particularly with endocrine diseases, are at higher risk and should be discussed for prophylactic fixation. Essentially, this is a complex condition. It should involve specialist senior pediatric orthopedic input in an MDT approach with a shared decision-making process with the family. So this is a complex topic. It's quite difficult. I would go over it and read around this topic on Ortho Bullets and your other resources and consolidate. And I wish you luck, and I'll see you in the next episode. Take care.